Okay. I think we are live. Were you saying something?
Hi, Vijita.
Okay, we are still in a practice session.
Hello?
Hello.
Hi, Vijita.
Yeah, are we ready?
Yes, yes, we are ready. We are ready.
Yes.
So we can start with today's webinar.
Yes, yes, yes. We can. Just let us know when we are on live.
We are all live. So we can just start with, yes.
Okay. Just a minute, I'll confirm. Vijita,
I think we can begin. That's what she said.
no, ma'am. Actually, participants
Hello?
are getting some glitch. Vijita, actually, participants are getting some glitch. They are not able to join.
They have to just refresh and join because I was also having the same issue. So that is Zoom glitch, maybe. So they can just start joining in because I can see few people have joined.
3 people have joined.
Yes, few people have joined.
Can we see the participants who joined it? Because I can see only me, ma'am, Vijita, and Farz also there.
What do you want to do?
Now we
You
can.
can't.
Now we are ready. Now we are ready.
Okay, fine.
Okay. So hello everyone. Good evening and welcome to all. Today we are all here for the webinar focusing on HFNC in pediatric patients and gearing up for third wave of COVID-19. The first half, we'll be hearing the session from speaker, followed by the question and answer sessions. Nowadays, we all must have heard about the practice of HFNC and its guidelines in the treatment of COVID-19 patients. So to discuss more on the use of HFNC in pediatric patients in COVID as well as non-COVID, we have here on our panel, Dr. Lakshmi Shobhavat. Dr. Lakshmi is consultant pediatrician and intensivist. She is currently associated with BJ Wadia Hospital, Mumbai, as an assistant professor and having vast experience. Her area of expertise includes growth monitoring, child growth management, pneumonia, child vaccination, newborn baby care, childhood infections, and pediatric ICU. So special welcome to Dr. Lakshmi on this platform. Over to you, ma'am.
Thank you, Dr. Ratnakar, for this warm welcome. Thank you, Fisher Baker, for the opportunity. And without wasting a lot of time, let's start. Just a minute. Is it now? Okay. Sharing.
It's visible, ma'am.
So we begin with high flow nasal therapy, oxygen therapy in pediatrics and children. And it has been a very popular mode of treatment for children in the ICUs, where I remember somewhere around 8, 9, 10 years back, maybe we were still new to how to use a high flow oxygen therapy in the ICUs. Whereas once we started using it, we got so familiar and we knew which patient to put it on, and we were so happy with the results. It's almost within 2 hours, you know what to do with the patient, whether the child is going to give you some time, or whether you're just having to go ahead, escalate therapy for the patient. It is a very easy to use tool for pediatricians as well as pediatric intensivists. So there's been number of published literature in about high flow in children, in neonates. It began in the neonates, and then it was studied in adults as well as in pediatrics. So basic components of high flow are, you have a blender which gives you the accurate FiO2 delivery for the patient, and you have a flow meter which is a high flow meter. Then there is a humidifier which humidifies the air, and then is the circuit and the nasal interface. So the nasal interface also is a very well made product which sticks to the which has wings on which it sticks to the baby's cheek, and it's a very comfortable device for the child. The child can continue to feed, continue to talk. If you've looked at NIV, there is a lot of pressure on the face of the child. There's a lot of damage and because of pressure to the nasal bridge. These things are avoided in high flow. Whether these two are different modalities, of course, but wherever you can, if you can use a high flow, it makes a lot of sense and a lot of comfort for the child. So what is a high flow? So basically, when you look at a child or an adult who's breathing with a lot of effort, you will realize that there is an increased flow rate which is occurring at peak inspiration. Okay, at the inspiration, there is a high flow rate which the patient desires in order to take care of the increased requirements of the child. Okay, there were physiological studies which were done which said that at least 1.7 liters per kg per minute. So it got rounded off to 2 liters per kg per minute. And this is how high flow is at present conventionally described. That is the flow there is no actual number, but these are the best numbers that we have. Okay. Earlier, it was up to 6 liters per minute, but we have gone higher. So how does the high flow really work? Okay, so high flow device generates a flow, which then, if you look at this cartoon here, washes out and fills the anatomical dead space with a fresh flow of gas. This fresh flow of gas will have the amount of FiO2 that you want to give to your patient. So this decreases the inspiration of depleted oxygen deprived air from the dead space, and it improves your alveolar ventilation in process. You also have, because this is a well humidified servo controlled humidifier that you connect your patient to, you get good humidification, which is important for good ciliary clearance of mucosa and the function of the cilia in the respiratory epithelium. As I said, the system, if you have used these prongs before, you know that they're very comfortable and very soft and pliable for the babies. And even the spring-like wire thing which is attached to the patient interface is very pliable. It is not a very stiff thing which pokes, or it doesn't make it very uncomfortable for the patient. Okay. So this is how its main functions are. And what are the outcomes that you get? Okay, what are the outcomes that people have studied? It improves the breathing pattern. It decreases the respiratory work of breathing. And it also causes a small stenting of the airways. Okay, there is no actual number that we can calculate on how much pressure the nasal high flow therapy can generate. There have been attempts to find out. I can't remember the number now, but it's not very high, not more than 4 centimeters of water pressure. It's not said to be more than that, is the amount of pressure which may be generated because of using a high flow device. So it does stent the airway and helps in keeping the airway open. It's much more useful when you have children with soft, pliable, you have laryngomalacias, you have tracheomalacias, and you have even some of the vocal cord palsies, which may benefit with little stenting of the upper airway. Okay. So how do you prescribe the high flow to your patient? You begin therapy. Traditionally, this is how it is used. It's 2 liters per kg for first 10 kgs, and then you can add a half a liter for anything above the 10 kgs. So you should actually be writing it out on your prescription sheet like this, and you should put a start time to it, so you know in how much time you need to get back. And look at your patient again and decide on whether the therapy is working for the patient or it's not working for the patient. It is very important that you note down baseline respiratory dynamics, the respiratory rate, your saturations, your if you have a nasal ET or a ETCO2 measurement, it won't be called an exhale and end-tidal CO2 measurement, then it is a good idea to measure those too. So the temperature that it is set at is around 34 degrees, which comes automatically with a servo controlled humidifier. And we've already discussed the flow. The max flow is 50 liters per minute. And FiO2, you would start at 0.4 or 40% FiO2. You may increase up to 60, but there is a caution to this that I wouldn't keep increasing my FiO2 in order to get my saturations if my patient is not settling down. Okay, my saturation should be around 92, 94, 95 is a good saturation to reach, but I wouldn't just be using FiO2 all the time. Okay, so if it's a new patient that you're waiting to see, watch which ways he is going, I would not wait too much. I wouldn't push my patient to 80% FiO2 and want to still continue on high flow. I would call it a failure of the high flow at that time. So we know that you would look at the respiratory rate, the heart rate. Both these will come down significantly. Up to 10 to 15% from the baseline is a decrease which is noticed in the first 30 minutes of starting therapy. This has been documented in multiple studies. Okay, the work of breathing comes down, and obviously your saturations improve. Now, what like I said before is watching carefully when you have that borderline patient who you're watching in your ICU. You have to train your juniors also to know where to say that the therapy is not working. So if you do not have any decrease in heart rate, if you do not have any improvement in saturation, if you're having to go up on your FiO2, if you do not have any decrease in respiratory rate or even the comfort that the patient is feeling, then you will consider you have to act. You have to have your plan B with you even when you use this therapy. So these are the different sizes which are available. So everybody from a premature baby to a big, large sized adult. These are my children. Okay, so I even know the numbers now because I know what I need to look for and what makes the babies comfortable. You can actually, though these are only the nasal interfaces which are displayed in this slide, there is a possibility of putting high flow through to the tracheostomy. So I just have a patient just now who is on tracheostomy but is on connected to a high flow. So you just have to order a different connector to connect this to the high flow tubing. I'm sure they will show you the picture if you want. If anybody has a tracheostomized patient who needs high flow, you can talk to them. So there are multiple indications. Okay, initially it was just in prematures, then it was only bronchiolitis, but we have explored how and when to use it and tried our best to use it in maximum number of patients. One of the biggest advantages I feel is that it is a non-invasive therapy. So being a non-invasive therapy, it adds to a lot of comfort. It decreases if you can avoid intubation in a patient, you are saving your patient from multiple, increased doses of sedation. You're saving your patient probably from a hospital-acquired or a ventilator-acquired pneumonia. So the advantages are manifold if you can actually give it a try in a patient. I'm not saying you would use it in a patient who is in cardiopulmonary arrest, who is in those kind of situations where he needs to be on the ventilator, but a patient who is still borderline, who may come off the high flow with optimized flow and oxygen, it is worth a try. So the common indications are asthma, cystic fibrosis, because cystic fibrosis, as you know, is such thickened secretions, and if in that patient you're giving him simple oxygen via the nasal prong, it is cold, it is dry, and the patient secretions just will not move. As it is, we are struggling to get rid of secretions and clogging in a patient of cystic fibrosis. Immunocompromised patients with respiratory failure, I don't want to intubate a patient who is an immunocompromised patient. I know I will give him something from my ICU and I will have to struggle with him further in a patient. So I don't want to do it. I would like to keep my patient off the venti as far as possible. Okay, we use it in patients who have and in a post-extubation respiratory support also. Okay, what you don't use it in is recent nasal surgeries, epistaxis, basilar skull fractures, and patients with low GCS. Okay. So bronchiolitis, popularly studied, lot of studies, many studies compared it with high flow versus standard oxygen in bronchiolitis, and there was no difference in duration of oxygen therapy in ICU, but there was a lower rate of treatment failure. Okay, so I have this in various in various studies, they used various permutations and combinations. Somebody used 1 liter per kg, somebody used 2 liters per kg, and there was somebody who even used 3 liters per kg. And when they used 3 liters per kg, they said that no, it's too uncomfortable for the patient. Though they didn't find any increased pneumothoraces or any of those concerns were not there, but they found it more discomfort. So right now we're still at 2 liters per kg for children. Okay. So if you look at this one, I need to get rid of this. Yeah. In this HFNC versus low flow nasal cannula for bronchiolitis, they said that fewer children experienced treatment failures. Only 14% of the children experienced failure, but those patients who failed were much more happier. So 61% of those who failed conventional therapy were happy to be on high flow and were managed on high flow. That's a big positive for the high flow there. Okay. Now you have a randomized trial of oxygen therapy again with infants with bronchiolitis. Now this was published in 2018 in NEJM. They finally had around 1,500 patients who were equally divided. And if you look at this Kaplan-Meier graph, you can see the beautiful difference in the graph. There's a nice difference in the number of treatment see the number of patients who had treatment failure or poor response to standard oxygen therapy. This is all bronchiolitis. Now, everything that is shown can be one-sided. So there was a systemic review which was published recently in the BMJ, and they had a lot of studies. There's one from India also in this, and huge sample size, all of them in which the intervention type was HFNC. The control could be standard oxygen therapy versus nasal CPAP. All of these were studied, and let's see what they found. Okay, they also found where the biases in the study. So there were a lot of biases in each of the studies that were selected in the thing. And you can look at, this is comparison of high flow to length of stay. Okay, so there was no great advantage of length in high flow, in the high flow group. Whereas if you look at, if you look at the oxygen, that the amount of oxygen, length of oxygen that the patient needed in the same study, you can see that HFNC had lower oxygen need in the patients. I would call it a big plus when you have low oxygen need by the patient. Okay. Similarly for asthma, now this was a pilot study for 62 children with a pulmonary score of more than equal to 6. The score is right here, explained for you if you want. And after initial therapy of bronchodilator and steroids, they were randomized to high flow or standard oxygen therapy. And what did they find? They found that after 2 hours, the pulmonary score had decreased by more than 2 points in 53% of the patients, whereas in the HFNC group, whereas only in 28% of the patients in the standard oxygen flow group. So though this was a pilot study, we'll have to wait for a bigger study which comes from this group. Post-extubation, yes, you need some stenting of the airway, especially in a younger baby. And in this baby, because of keeping a tube in the vocal cord for a long time, there is glottic edema. Whether you like it or not, there is glottic edema. And like I said, the edema, the stenting of the airway, which can be created by the high flow, is very comforting, and you will have patients tiding over to, especially after cardiac surgery. It works beautifully. Okay, so this is a Turkish study which compared high flow in pediatric intensive care. So they started with a high flow of 1 liter per kg per minute with an FiO2 of 40%. And if there was no clinical improvement, they went up to 2 liters per kg per minute, or maximum 25 liters, and FiO2 target an SpO2 of 92%. And they said that it was better in the patients who were started on high flow had a higher SpO2 values, and their SF values, therefore their SF values were also better within 45 minutes. So this is how fast you can see your results in patients. This is post extubation. Okay, and this is pediatric intensive care. It is not pediatric cardiac intensive. Okay, so now let's see outside the PICU. Okay, so will you use it outside the PICU? Yes, I will use it. I have been pushing for wards to have one machine at least in each ward, so that you do not waste time in stabilizing your patient. You're able to deliver the high flow to the patient when he needs it, instead of wait for him to worsen, increase your medication, increase your nebulization doses, and then treat your patient. So various studies here which said that you may actually decrease the need for ICU transfer, you may decrease the need for intubation, and I'm sure this is a big positive. Is it economical? Really? Okay. So a child with a neuromuscular condition, where we know if we put the patient on ventilator, it is extremely difficult to get the child off the ventilator. The child becomes ventilator dependent. So if I can keep the patient outside the ICU, where the costs of ICU care are so much more higher, why will I not use it? I don't want patients to be in the ICU. I want to just take care of them and then push them out and then take care of the next set. I don't want patients stuck in ICU. So it is a great device. It helps me decrease my PIC. It helps me improve my PICU turnover. So it is economical both for the doctor and the patient. So COVID-19, okay, just a quick word on COVID-19. Which are the patients who need inpatient care? Because we will be probably facing the COVID-19 one more spectrum now, and they say the children will be more affected. So with moderate to severe illnesses, we will be needing inpatient care, okay? Moderate illness is a pneumonia. A pneumonia, again, will be benefited by a high flow device. Now, I remember when the beginning of the COVID epidemic, pandemic, they said that there is a lot of aerosolization from NIV. Don't use NIV. There is a lot of similarly, there is a lot of aerosolization from high flow, but they have come back to not just the aerosolization, but also the treatment therapy. Putting a patient on ventilator, I'm sure you've read so many other articles that you've put a patient on ventilator in a COVID patient and he actually does worse. Okay, so we have seen those. We've tried our best to not intubate. So any patient who is ARDS, who has SpO2 less than 90, this pneumonia is somewhere around 92 or 94, and severe ARDS is anybody less than 90. So these are your patient population that you're looking at. So now this is an adult study using high heated HFNC in COVID-19. It's a retrospective study which was done in 4 months in the early 2020. They just retrieved the electronic data that they had generated. Out of 193 patients, 21% of the patients, that's 41, received high flow. And of these, the 70, that's out of the total, 76.5 are less likely to receive mechanical ventilation. So wasn't that a fabulous job they did? Just by using high flow cannula there, they could prevent mechanical ventilation in a COVID-19. I don't know, I'm sure all of you have seen what COVID-19 has been. You know how doctors are afraid to put patients on the ventilator. It is chaotic inside the ICU, in a COVID ICU. So I would be really happy to do this to any person who has a COVID-19 and who needs who can be managed with a high flow. I will be using a high flow. So this is data which I recently did for a COVID presentation, but it was talking more on awake proning in COVID-19. Proning is a big yes in COVID-19. Please start practicing prone sleeping, prone lying down, because sometimes patients feel uncomfortable. So if it's a practiced maneuver already, even you're in health, then in your sickness, you may be benefited by learning to be in prone. So these are all patients who are adult patients who are on triple HFNC, who were randomized to proning and non-proning. And obviously the proning groups did better, but they all were on HFNC. I'm sure you can imagine putting a big NIV mask on this patient and making the patient go prone and then go lateral. It is so uncomfortable. Half the time the mask would be moving here and there and your seal would be lost. So I am again proposing that we continue with high flow as far as possible. These are premature infants, and there are multiple studies which are done in young babies less than 32 weeks, and compared with nasal CPAP, there was no significant difference in rate of extubation failure, but less nasal trauma. And especially for that premature baby, the lesser the nasal trauma, the beautiful the nose is after when the baby is given to the mother is such a big relief. So those are the only things that I have to share here on this presentation. If there are any questions, I'm okay to take them. I'm going to stop sharing now.
Thank you, ma'am. Thank you very much. There are some questions in our chat box.
Okay, can I read them? There are two.
Yes, yes.
What are the major challenges you were facing before triple HFNC was invented? We didn't know if we could use something. So I think the heating and the humidification to the nasal flow makes such a big difference that the baby doesn't complain at all. The baby doesn't do this and pull out, the nasal prong. He's happy to be the way he is. He is ready to eat his food. He's able to take a breastfeed. It is much, much, much more comfortable. Other times, I'm sure I've even faced problems with the prong not staying in the nose, the prong just coming out all the time, the prong being like this and the baby being like that and that thing being there, the prong being here. The fit, the comfort and comfort to the baby doesn't pull it out. So that is what I faced before. I don't face it now if I use this device. Okay. The other question was what was the biggest flow that I have used? I have used it in I can't remember the numbers, but I can tell you I had a big girl with almost 11-year-old girl with cystic fibrosis who was a chronic patient. And what we did for her was we made her buy her own prong, and we would, every time we would just give it back to her because she had these episodes where she would keep coming back to us. So she was around she was thin because she was a cystic fibrosis. So, but she must be around 16 to 18 kilos. That is my biggest child that I have used a high flow on as far as my memory goes as of now. We are also using high flow via ventilators. So in that, the patient may be a bigger sized patient. So maybe a 30-kilo child. You just have to do the multiplication. Do you advise intermittent therapy of NIV and HFNC? Not really. No. If I am facing respiratory acidosis, and if it is I have to figure out the reason for that respiratory acidosis before I decide what kind of therapy I want to use for the patient. But can I get the question back? Yeah, so I wouldn't switch between NIV and HFNC. I use NIV for as long as I feel the lung units are functioning. There is no alveolar problem. If I have gone from invasive to non-invasive and I think he will need a high flow. My best ones have been on high flow are the ones who have had staphylococcal pneumonias. They look horrendous on the X-ray. They look horrendous on the X-ray. You're afraid to pull the tube out. But believe me, when you do pull the tube out and you put them on high flow, they do beautifully well. Okay, so it is a question of, you know, breaking your own mental barrier to use of a high flow rather than not use it. What is the highest flow? There's a lot of misconception.
Ma'am, there is one. Yes,
yeah.
There is one another question.
What is the question? This one, na? There's a lot of misconception regarding oxygen consumption on high flow use in COVID-19. So I'm sorry, but you know, it was very silly the way it was touted that high flow uses a lot more oxygen than a ventilator or a NIV. It just uses the oxygen that you titrate in. It is a blended mode. So if you want to use 40%, it will give 40%. If you want to use 80%, it will use 80%. That is how you dial in your oxygen. It has got nothing to do with the patient. We can't be saying that, you know, the high flow will use more oxygen. The patient will need the oxygen the patient needs. And you will dial in that much oxygen based on the saturation target you want and the effort of breathing that the patient is having. So if the patient is failing high flow, I definitely need you to know that your patient is failing high flow. I will not dial in 80% in my high flow. I will take a call again as to why I need higher oxygen. Does my patient need non-invasive support? Does he need more some other kind of support? I really need to think about that before I just keep dialing in my FiO2. Yes, I have used HFNC in wards because PICU beds are at a premium, never available. So I push the machine down. I tell them how to use the machine and I go see the patient after some hours and see how the patient is. That's it. Are there any quick deciding guidelines when to start HFNC? So, so we know the indications. We've seen the indications. I will obviously be trying HFNC for all the indications that we discussed just now. So, quick deciding guideline means you want me to give age-wise cutoffs for severe respiratory distress. I may not use it. I will still keep it for mild to moderate, and the moderate should go to mild in the next 2 hours, or should show signs of settling in, should not show signs of the CO2 rising or child becoming drowsy. The child becoming drowsy at any point is a big no-no. Okay, so then you shift and then you don't push your patient too much. We did discuss HFNC in CF and post-cardiac surgery. What, any other remarks you were looking for? Yes, I will use it in cystic fibrosis because cystic fibrosis has very thick mucus plugging. They cannot mobilize. Plain non-humidified oxygen is a very bad mode of delivering oxygen to a patient who is a cystic fibrosis. So it is beautiful to use a triple HFNC on this patient. Post-cardiac surgery, yes, you'll use it for titrating your, sorry. Any other questions?
Yes, yes, there is one question.
Okay. Yes. Yes, absolutely. Why not? When something has been provided and it is supposed to be used, why will you not use it? The minute you put your patient off, I'm sure you don't have the next patient waiting. So you go ahead and sterilize your high flow with it. And then you're ready to go for the next one. I want you to show us those two pictures on how to connect if you have the tracheostomy connector picture, and also the nebulization on high flow, the connector, the other device. If you can just show us those pictures, it will be nice. I don't have those pictures.
Ma'am. Yes. Is it visible?
Yes, it is. Yeah, we have this one on the child, and the child is so happy to be on it. He was otherwise, see, when you give, if you have a tracheostomy and you put a thermovent, I'm sure everybody is aware of what a thermovent looks like, and the thermovent is connected to wall oxygen. It is again giving very cold air and not humidified air. So the child ends up coughing a lot. If you can imagine cold, dry air going into if you go jogging in the morning on a December morning, then you know your nose will get blocked because you will run and you will inhale a lot of air, and which will be cold, and your sinuses will clog and you'll come back home with a headache. So that is what will be happening probably to all the other children in the ones where we are using these non-heated, non-humidified oxygen. And the other one?
Yes, ma'am. Just visible?
Yes. So here, see the traditional chamber, which is connected to the humidifier, has these two outlets, and to that, if you can just connect this one chamber here, then you can, and this wire goes to a modular setting where you can actually set how frequently you want the nebulization to start getting actuated. And once that is dialed in, you don't have to do anything other than the nurse having to see if there is enough solution in the chamber to give your patient nebulization. Yeah, I think this picture is much better. Yeah. So you fill this chamber out. I think you can tell us what the name and all that is for this. I don't know all that. Yes, Rajeshri, thank you so much. If there are no other questions, then we can call it a day.
Yes, ma'am. Yes, ma'am. So thank you very much, ma'am, for your precious time. And definitely the participants will apply the whatever you discussed about.
We still have very little for COVID to tell. I think it's only time which will tell us if we can keep it a very high usage. Let's see.
Sure. Okay. So
yeah.
Can we wind up, ma'am?
Yes, I'm okay.
So thank you. Thank you very much for your presentation.
Thank you.
Participation. Thank you.
Thank you. Bye-bye.
Bye.